That's great. So you talked a little bit about some of the changes in maybe your protocol and stuff. What is exciting and new?
So we deployed whole blood, pre-hospital whole blood this year. So that's new. That's exciting.
Very new.
Only 1% of services in the country are doing it. So it's huge. We are the first in Ohio to have whole blood. So there are other people in Ohio that have component therapies like packed red blood cells, plasma, but we are the first in Ohio to actually give whole blood.
Have you seen it work yet?
Definitely, yeah. So we have, like, I don't want to mess up any numbers, but we've given it 45 times so far.
So far since
June 4th.
June 4th of this year, 2025.
Yeah, so June 4th, 2025, we deployed. So Kim said we have 3 captains in the field. So we deployed it with 1 captain on the southeast side of Cleveland. The reason we pick that is because it's farthest from trauma centers. So it's about 10, 15 minutes from Metro or UH.
Traffic dependent.
Yeah, the southeast side of Cleveland. So and it's statistically like the most violent. So that's why we picked the captain over there, because to start the protocols, we're giving it to trauma only. Mm-hmm. Eventually, we're going to move into medical hemorrhage, but right now, just trauma. So we've given it 45 times, starting with only 1 captain having it. It was October 20-something that we deployed the other 2 captains. So
23rd.
October 23rd, the other 2 captains. So they've only had it for a month. Mm-hmm. So that 45 times was mostly only with 1 captain giving it.
And I like, what did you say the stat was? You got permission to do it, you carried it, and within how soon did you give it?
Within 5 hours it was given. Within 12 hours it was given twice.
And then when it was deployed, so on the west side, we saw a definite need on the west side. The captain was giving it on the east side, and then there were calls on the west side they just couldn't make it to. So as soon as the west side captain got it, they gave it within hours too.
Wow.
Yeah. So I think we have what was that number for survival?
I think you said 32 walked out of the
Yep.
hospital.
32 discharged, 13 deceased.
Yeah.
I mean,
It's
it's over.
working.
It's over 60% survival.
Well, I mean, to be honest with you, and I don't know your exact protocol, but most protocols and how they're written, they're circling the drain anyways. I would argue that all 32 would have passed without blood.
Absolutely.
Yeah.
Well, we have
Yeah.
a specific criteria that we have to meet with blood pressure and heart rate and capnography and all of those things.
Why don't you talk about it?
So,
Okay. So you have to meet the mechanism of injury. Mm-hmm. So we mostly follow. It's mostly goes along with trauma knots.
Knots
The knots protocol of the mechanism of injury. So you have to have a mechanism of injury and then a vital sign that matches. So heart rate greater than 110, blood pressure less than 90, capnography less than 25. You have to have 2 of those, or a blood pressure less than 70 standalone. So if you're like profoundly hypotensive, 70, then we can give it.
With active hemorrhage.
Right. Trauma for right now. We're going to revisit the medical side, giving it for medical hemorrhage, but right now just trauma. So you have to have a heart rate over 110, a blood pressure less than 90, or heart rate and capnography, blood pressure, capnography. You have to have 2 of those.
unless they're on beta blockers.
Yeah. Obviously, we take in consideration beta blockers.
So you warm my heart by saying that, because it's something that I always talk about with medications, is that you have to know what meds the patient's on. And I talk a lot about beta blockers because they might not be able to mount that tachycardia, and
Correct.
you have to be able to realize that.
Yep.
Otherwise, I would expect this person to be tachycardic. If their blood pressure is circling the drain, why aren't they tachycardic? Oh, they take metoprolol.
Yeah.
That's why they're
I'm
not
clinically
tachycardic.
unable to get
Yeah,
tachycardia.
my heart will not do it despite what all of my body's trying to make
Yeah.
it do.
And we teach to look at the whole big picture of the patient. Can you feel a radial pulse? Do they look diaphoretic?
Treat your patient, not the machine.
Yeah, are they altered? Look at the big picture. Is capnography not reading because it's not staying in their nose? Can you not get a blood pressure because it's so low and you can't hear it? Just give us the big picture. And our medical director, he's very involved. And as long as you can paint the picture and you think the patient needed blood, we need 2-person verification. So the captain has the blood, brings it, the paramedic on scene, both of them together have to decide, yes, this patient makes the criteria. The captain has the final decision. Okay, we're going to give it. But if they talk about it in, like I said, you're looking at the whole picture. So if for some reason one vital sign is not specifically where it needs to be, the captain and the paramedic can still make the decision. And we can always call Med Command.
Yeah.
We can call Med Command and be like, listen, we don't think that the monitor's reading right, or I can't get a blood pressure because of this, or the capnography's not reading because of this. But here's the picture of my patient, and we want to give blood.
When you're giving blood, do you guys give any adjuncts with it, like TXA? Do you have calcium with it? What's your protocol?
Both.
Okay.
Yep, TXA and calcium.
Yeah, and we teach them to try to get multiple lines, obviously, because once you establish that line with the whole blood, that's all that goes in there.
It's going to be a very busy line.
That's it.
Yeah.
So then the other one, we're going to do the TXA and try to do the calcium if we have time and we can.
Are you also providing antibiotics for open fractures?
No.
No.
Oh, okay.
No.
When you guys are administering blood, just more curiosity, are you guys giving fluids at all with it? Do you guys limit your fluids, or you just go straight to blood?
Straight to blood.
Yeah, limit fluids, for sure.
Sure.
Yeah.
Okay.
And we don't have lactated ringer. We only have normal saline. So
I'm
we
a
know.
sailing guy, so you're okay with me.
Oh, okay.
Well,
We
you
just
can't.
had this conversation
Really?
not long ago.
Lactated ringer and whole blood don't match anyways.
Right,
So-
right.
There's that.
Yeah.
So no point of having lactated ringer now that we got
right,
whole blood.
right, yeah.
So you mentioned your protocols. So who are your protocols through for Cleveland EMS? Obviously, for university hospitals, we're through university hospitals.
So we're county.
Mm-hmm.
County protocols.
So the regional
protocol. Mm-hmm.
Yeah, so for the viewers that aren't familiar with North State Ohio, we have a regional protocol that Metro's on, UH is on, Cleveland Clinic is on. We all agree on a regional protocol. Individual ones might make small footnote changes, but generally it's the same protocol, which is actually super nice for lots of reasons. That even if you're picking someone up off the side of the road, like, oh, I'm a paramedic in Munson, I know your protocol because it's the exact same protocol, right? So from that standpoint, it's very standard. It's essentially standard of care in Northeastern Ohio. Very interoperable. If you have people that work on Cleveland EMS and their B job is somewhere else, they can very easily switch between the two, whether that's a university hospitals, Cleveland Clinic, or Metro Med Command. But you guys are interesting that you switch who you guys call
Yes.
for med control questions.
Yeah. So I apologize. I don't know which
Metro
is which.
odd days.
Metro odd days. So Metro
So
odd.
Metro's odd, got it.
And then UH for even days. I always have to ask. I forgot.
Yeah. Some people just call one, or they'll accept a phone call no matter if they're Med Command or not.
Of course.
There's some people that I just call Metro, or I just call UH, and they've never said we're not Med Command today.
Honestly, the person answering the phone probably doesn't know.
Yeah.
And you're the one of 500 calls that they get during the day. It's not even moving the needle for
Yeah.
them, right?
So Med Command for blood, we just call Metro.
That would make sense.
Yeah.
So obviously you're targeting Metro for trauma, which I think we would do mostly the same anyway if we're flying somebody for burns or trauma. Probably going to Rainbows for babies if you can.
Well, we go
Closest.
we go to UH too. So it's been pretty split. You have so Metro, we've taken for blood, we've taken 21 patients to Metro and 23 to UH. So we've actually taken more blood patients to UH, mostly because we started on that southeast side of Cleveland, and you can get to Metro from the southeast side. A lot of people go to UH though.
Yeah.
It depends on how far into the southeast side you are. Sometimes you can just jump on the highway and get to
on
Metro
480, yeah.
a little quicker if you're deep into the southeast side.
Sure.
So.
I mean, University Hospitals has only been a trauma center for, do the math, 8 years now, right? 8, 9 years. And it's amazing to me that they weren't in the trauma game up until then, because as busy as a whole trauma system, you guys see it on the road, right? Imagine trying to haul from east side to try to go to
We had Huron
Metro.
Road Hospital on the east side.
Yeah, they closed.
Before UH though. That's where we went.
Because we even had, it was a mile from UH's emergency department, and it was a trauma, and we had to go all the way to Metro because at the time UH was not a trauma center.
Correct.
So it's a long haul, you know.
So for those not in Ohio, those are actually Ohio rules that state you must go to a trauma center. There are some exceptions to that, but
Yes.
you must transport trauma patients to a trauma center.
Yes.
Yeah, the law doesn't say you should. It says you shall, which means we have to. It's law. Ohio trauma triage laws.
Right.
So I got to tell you, for being such a high call volume department. I worked as a quarterback we have at university hospitals in some of our ERs for UH for a while downtown, and some of the best medics I met were Cleveland EMS that were coming in with patients, and I mean these patients were well packaged, were well triaged, and they were giving me numbers like Glasgow coma scales, which is we should be doing those on every patient, but they routinely did. I just thought, hats off to you guys for being as busy as you are. You're still giving superb care, and I thought that was pretty cool.
Yeah,
I appreciate that.
I do too. I
we have
appreciate
really
that
good
too.
people.
We do. We have amazing paramedics and EMTs.
Yeah.
I'm proud of all of them.
And I'm sure the high volume, like we had talked about kind of a little before, it's helping them be better. But obviously, it's weeding out the
that's a
ones that
sink
aren't.
or swim.
Yeah.
You're either going to make it or you're not in that environment.
Quickly too, I would assume.
Very quickly.
But
Yeah.
no, I thought that was cool. So as far as community goes,
Well, before you go there, we talked about blood and how that's been new even just this year. What you guys rolled out something also new just recently that's pretty advanced.
Ventilators.
Correct. So tell us about your ventilator trips.
So I unfortunately don't have any statistics for you. They came out yesterday.
How dare you not have stats for
Oh no,
yesterday?
but it was.
But it was
So
used once. It was used
November
once.
17th, 2025.
So
is when
November
we recorded
17th,
today. So
2025.
yesterday.
It was used within an hour. So it was throughout the day. The crews came down and got their vents, and one of the crews had it not even an hour and was able to use it on BiPAP. So I don't have a whole lot of detail, but I was told it was very successful, which I'm very excited about. We're hoping to see amazing things with it. We have custom settings, which is nice. And then if we have a trach patient where we have to go to the facility, then we can just kind of dial in their settings and kind of move on with that. So.
Yeah.
So
And you guys had the ability to do CPAP before. What devices were you using for CPAP before you guys got your...
I don't remember the
Were they like
commercial
disposable
name.
Palma?
they're
Dime?
they're the
So
disposable.
it's like the one behind you there.
And then
Yep.
your tank. So that was CPAP, but we didn't have BiPAP. So now we also have
Correct.
BiPAP with the vent. So we can do CPAP and BiPAP. We're still going to continue to keep the old CPAPs on the truck because that is an EMT skill to where
Absolutely, yeah.
the ventilator is not, that CPAP is not an EMT
Yeah,
skill.
great point.
So
Great
we
point.
want to be able to keep that available just in case something happens. So we're excited about it. So
No, it's
Yeah,
exciting.
really good
excited
things.
to see where it goes. Yeah. Something new all the time.
Yeah.
There's actually a
yeah.
really good podcast series on this podcast
On
network
CPAP.
on CPAP. So,
And we
I'll have to listen to it.
Yeah. Well, we talk a lot about, even here, and you guys know this, like, your best paramedic is going to be a good basic, right?
Absolutely.
They know all the
Yeah.
basic skills, and that's
Absolutely.
that's CPAP, that's bagging a patient, that's positioning an airway correctly, that's placing a tourniquet. All
The
real-
life-saving skills are EMT skills.
Absolutely.
Yeah.
correct.
I said I do not need a paramedic. I don't need a paramedic during a critical call. I need a good, solid EMT, and those we have.
Yeah.
We've put them through the EMT program. We've watched them grow. We've taught them, and they're pretty solid. I can't wait for them all to become paramedics.
And paramedics that remember that is what
Oh,
saves
they have
lives.
to, though. They have to.
Yeah,
because
it's
whenever a advanced skill fails, we fall back on our basic skills to save somebody's life.
and those are the proven,
Oh, yeah.
proven
Yeah.
skills that save lives.
So anything else on the vents?
No, I really
Are
don't.
those on every truck?
They're on every truck. I think everyone has them now. So we're gonna wait and see.
Do you guys do a lot of transports of, like, trach patients or already intubated patients or anything like that?
So we
You
have
probably don't have intubated patients, but for
So we have a
what's your
couple
interfacilities
facilities on the west side.
that
we
are
get
trached.
that are trached, so we get some calls.
Like nursing home facilities?
Nursing home facilities. So
There's a couple regular patients that are in houses that call, but
Sure.
I mean, it's not a regular. It's not a regular call for us, but we have definitely the nursing homes
Yeah.
or skilled.
LTACs
Yeah,
or
and
SNFs.
yeah, and then a couple people actually in the house.
yeah,
that
we
we
are
transport.
not using the ventilators on pediatrics though.
Okay.
So if we do have a pediatric who's on a vent, we can keep them on their ventilator with whoever trained staff is with them. So mom, parent, caregiver, however that is. And then otherwise we would just go back to our basic
Yeah, bagging.
bag and the kid.
So
Saving
a
lives.
we've had issues where squads have turned down transports because the patient was on a ventilator and they're not trained to its bag.
Bags.
Oh, yeah, exactly.
Right.
Just bag.
If that, but if they're, if let's say you get a
Family.
call and let's say they're altered and so urinary tract infection, right? Take the vent with them.
Yeah.
They're at home on a vent. It's going to be fine in the ambulance.
And to your point, I don't know, I wasn't on the episode with Tony, but I would tell the medic students they're most comfortable on their vent. If you have that option, take them on their vent. So,
And even if
yeah.
you are copying, if you're transporting from their home vent or a facility vent and going to a different vent, even if you're matching settings, it might be delivering
different.
air a little bit differently, and it might be uncomfortable for the patient. They might desaturate. You might have to change those settings.
Yeah.
Which, if you're interested in ventilators, we have a great podcast on that.
So
that
we
do
are
talk about.
taught if we have to change over onto our ventilator, make sure they're on their bed, they tolerate the vent before we're doing anything, before we're
Yeah, great.
transporting, before we're moving. And then again, we just revert back. We have our AccuVent, so the real BVM, just go to that. Put it on the monitor. I don't know if you guys use the AccuVents.
Do you know what that is?
Do you know what it is? Okay. So it's this little blue piece.
Yeah. The blue guy.
The blue guy, and it's attached to our monitor, and then you put it on the BVM, and it gives you your tidal volume, so you're not giving too much tidal volume, and then it basically counts down. So 6, 5, 4, 3, squeeze. And then you're watching your tidal volume, so we're not
that's
overinflating
great.
and doing any kind of trauma.
If
to the
Scott was
lungs.
here, he'd go, yeah. I know this.
So we have them on all of our trucks, and we encourage everyone to use those for everything. Just like we're pushing capnography for everything. If you're bagging somebody, do it. And it's great because, high stress situation, you have a fireman who's maybe new and unsure. Okay, this is going to count you down. Don't go over.
It's like a little circle that fills up. And you just fill that circle, and if it's the right, is it green? I
Green.
think it turns green, and then that's how much tidal volume we're supposed to
Something
give.
to look into.
Because definitely
They're disposable, obviously, so they're
Yep.
pretty cheap.
Yes.
yeah, I don't know how much.
I don't know how
cost,
much they are.
but-
Yeah.
Yeah, but I mean,
it
we
helps
have
so you can say, "Hey, EMT bag, I'm gonna watch. I can monitor
Watch
what's
that.
going
Yes.
on while I'm
Yeah.
managing."
because
the
pre-hospital it can be an issue with overbagging.
Yes,
And-
absolutely.
And that's obviously we know not good.
Right.
With
Not
cardiac
good.
output and
Yeah.
everything.
Are you also RSI certified?
No.
No. Okay.
What do you guys do for intubations in the field?
So if we have a respiratory self-awareness, we can use ketamine. We have ketamine
Yeah.
currently. So
Ativan,
ketamine, ketamine, fentanyl.
fentanyl.
And we've had this
You
conversation.
guys carry Ativan? Okay.
We've had this conversation before. My department is RSI certified now almost 4 years. We've used it once.
Okay.
And it's like, obviously our volume isn't where yours is, but at the same time, in 4 years, it's almost like every time we've needed it, ketamine's been enough. So,
Typically.
yeah.
Yeah, so how long we've had ketamine for about a year? you
About a
think
year,
now?
I want to say.
I mean, crews definitely use it. It would be good for us. We should get some statistics on that. Just curious now that we're talking about it on how often we use it and how successful it is.
For taking an airway.
Yeah, for taking the airway. Because,
Yeah,
I mean, we would
it's-
like to have RSI. That's something we always try to
Yeah, we've talked
push
about
for.
For them, it makes a
It
lot
makes
of sense.
perfect sense for Cleveland EMS. I mean, with that volume, and now that you have your vents that you do with BiPAP and everything, I mean, yeah.
Well, you're essentially telling me that I can't use RSI, and that is my go-to way to managing an airway. It's a very rare occurrence I'm not paralyzing a patient during my intubations. Not that it doesn't happen, but
And nowadays, with so much help with intubation, we have video scopes, we have the bougie, we have so many ways that you should be able to get an advanced airway. I
Yeah.
mean, we have eye gels too, but like,
but that's your fallback, right?
Yeah,
ET
you-
tube is still a gold standard.
yeah, you
Absolutely.
should be able to get that
It is.
airway. And if not, you have the eye gel.
It just comes back to oxygen reserves, making sure that the patient's ready to accept that you're electing to take somebody's airway at that point. God, I could preach on this all day, and it's not the
know.
episode.
It's
so-
not. For your airway, do you guys always intubate with a bougie, or is it
Just an option.
yeah,
option?
an extra tool. Yeah.
Yeah.
Because the data out there suggests that we probably should be doing a bougie every single time. I wasn't trained that way. I was trained old school where I trained on DL. Video was a
Yeah.
nice to have, even though almost all my intubations now are video, except for when I'm intubating like a cath lab or on the floor somewhere, and then it's going to be direct because I don't have my video to lean on. But I'm still direct without a bougie, and bougies might fail to, and I've had to fail to it 2-3 times, and I'm successful with the bougie if I have to fail to it. But and we talked about it again. We have a whole course on airway actually, where we talk about how you plan to fail in your airway and what your failure points are going to be, and how you fall all the way down to. Do you guys do cricothyrotomies in the field?
No, another thing we want.
We want. We
We're,
do.
we try to be really aggressive in our education
No, but
department to
you
try
should
to
be,
get
yeah.
whatever we can. If it's in our scope of practice, we
wanna
want to
do
do
it.
it.
Completely agree. Like myself, and probably anyone that works in EMS, we want you guys to work at the top of your licensure. Like, there's no reason not to. If you have that skill and the state says it's okay, we want you doing all the things because it's going to make a difference in someone's life.
Absolutely.
We talk that the basic skills obviously are the most important, but sometimes it comes to you need to use our advanced skill to save somebody, whether that's manual defibrillation, whether that's blood administration, cricothyrotomy. Those are advanced skills that sometimes you need to reach deep into your tool bag to pull that out to save someone's life.
It should be a rare thing, and it really
It-
is.
right.
And if you have a medic that's doing 10 of them a month, there's a problem.
Yes.
But yeah, no, I
Right.
agree that there is the occasion, and the one that we had that we used RSI for was a GSW, and the guy had trismus, and they needed to get in, so it worked great.
Yeah, those are the only cases that I've heard pre-hospitally that I hear maybe one every few years, but it's that I can't get their jaw open after
Yeah.
a trauma,
Yep.
and I can't get an airway, and those are the patients that
And I
are
would,
beneficial.
I'm glad they had that option at that point, and
Right.
that's why we still have it now, and hopefully we never need it again. But ketamine seems to work most of the time.
Yes.
We do well. A lot of my squads, I'm way more rural area. Like, you guys are obviously very urban. You guys aren't landing helicopters at accident scenes for transport because that seems silly. Because you can get them quicker to the hospital from that standpoint. What other differences do you see between rural, which is the majority of Ohio from at least land mass,
Second cornfield on the left.
versus like what do you guys see in the urban environment?
I mean, going along with what we were talking about of some of the stuff we can't do, like RSI, I feel like sometimes it's hard for us to get aggressive protocols because we're so close to the hospital.
Absolutely.
It's always you're 10 minutes away, you're 15 minutes away, and it's harder to fight for those what word am I looking for?
It's hard to fight for the advanced stuff when it's just
Right.
quick and easy to load and go. Like
Right,
skip it
right.
out.
Where you don't have hour transport, a half an hour
Yeah.
transport. So that's definitely a difference.
My rebuttal to that, though, is that sure, you're 10, 15 minutes away, but then you're also 10, 15 minutes possibly away if the ER's busy to getting that care then.
Yeah.
So why not just handle it when we have the ability? And
Well, and
Yeah.
those patients are probably they could have used that intervention 10, 15 minutes
10,
prior
15 minutes
before you even got
prior.
there.
All right, you guys go call the powers to be. tell them we need all the cool stuff.
His name's John Hill. No, I agree. And it's probably hard to fight for something. And being here at Munson locally, you know, we're 10 minutes away from the hospital at some of our furthest destinations. So it's hard for us to fight for some of those things, but even RSI, we've used it, you know. So I could fight for both ways in a lot of cases, but mostly I'm always pro EMS. I want to see us, you know, let's use our skills that we have.
We're more diverse, maybe. Like, do you think that urban is more diverse than rural? Like, you see every walk of life.
Yeah.
By the time you've worked for Cleveland EMS for a few months, you've came across so many different kinds of people, which is a good thing.
Yeah, it's a
Sure.
great thing.
So that's, I think, maybe a difference.
What about STEMI care? Are you guys giving heparin, Brilinta?
No.
No. And again, you're pretty close to cath labs, so I could understand that.
Yep.
You're activating them, though?
Yes. Well, we'll send off the EKG and, call, and then they'll tell us, that's not a STEMI, no.
Yeah.
But it's nice. And now we can take them to the cath lab, like directly to the cath lab if need be. So
Now
that's
that
good.
you
That's
weren't doing that
nice.
before?
So we would take them to CT for strokes, but cath lab, I had never taken a patient to the cath lab.
I personally hadn't.
So
Yeah, we do we do the 12 leads and send it to the hospital and activate. Most of the time they take us seriously.
Yeah.
Most of the time.
most of the
Yeah.
time.
Well, they should, and sometimes I'll even tell my squads, and I'll tell you a story. I told this last time we were recording, but it's a bit me as well. We should listen to what EMS is reporting, because sometimes you're stressed. You can't find the words other than I need a stroke team, I need a trauma team. This is what's going on in the field. I'm busy. Be ready for when I arrive. Right. My story is I had a squad that requested a stroke alert. They told us the whole story. I'm like, that doesn't sound like a stroke. We'll just see them when they get here. And within 3 minutes of me seeing them, of course we're calling stroke alert. And I should have listened to my squad and activated the stroke alert prior. We ended up giving them thrombolytic. He improved in the emergency department, which is probably a great save from that standpoint. And EMS called it before I even saw the patient. So.
It's different now. I mean, I also started in 2004, so I've been around a little bit. We weren't diagnosing patients in 2004. We were just getting them to the hospital. And if they had pulses, I won. And now it's like I'm trying to tell him what I think is wrong. And if I don't know what's wrong, I'm going to tell him what's not wrong. That way he can work on what is wrong, not reinvent the wheel. So I think that's been totally different since my career started.
We expect a very high level of care from whether you're a basic, you're advanced, you're an intermediate still hanging out, or you're a paramedic. We expect you to be, I even start we talk about this when we do training too, even though we're teaching, like, say, a paramedic skill, I want my EMTs to be able to kind of pick up on that motion. Like, yeah, sure, you can't interpret, by law, you can't interpret EKGs, but you go, oh, that looks ugly. I need to send that.
Yeah.
To
I need
somebody
to
who
call
can
some. Yeah,
interpret.
exactly.
Yeah.
So have that wherewithal of be able to pick up on the more advanced skills. And we talked about protocol before, and like protocols, as you said, a cookbook, right? And sometimes, and multiple times, your patient's going to fall underneath multiple protocols. So you got to combine all these protocols into the care of the patient. And sometimes you're going to have to pick and choose what you're going to do with inside that protocol, because it might work against what your ultimate goals trying to be. And that's where we want the care of the pre-hospital provider to be, whether that's basics or paramedics, to be like, I understand what's going on and I understand how I'm going to fix it, not just, oh yeah, they're short of breath, you got to do it now.
It's very
It's a lot
rare,
more complicated than
I
that.
think, that I come across the chart that I review that the paramedic was just, I have no idea. Just, hey doc, take this. I don't know. It happens, but it happens
that's okay
with you too in
too.
the ED sometimes.
You can either call or deliver a patient and say, I don't know what's going on, but I don't think it's this,
Right.
this, and this because of this. Great. That gives me a great place to start off with, not just, I don't know what this is. Like, I need more than that.
Right.
I don't know what this is, but I've ruled out, it's not
Rolled
attention.
out this.
Well, it's not an MI, right? Here's the EKG. It's not attention to a thorax, although their baby hypoxia, they got better on supplemental oxygen, but there's no tracheal deviation. They got bilateral breath sounds, right? They're giving me feedback as so they understand the pathophysiology of what these disease states are, and they're being a better clinician than just a technician that's saying, oh, you do this, I'm a monkey. I do
Yeah.
Yeah, and that separates us from ambulance drivers too.
Correct.
Right.